ऑनलाइन प्लेटफॉर्म पे हम एकत्र हुए हैं। रानू रहंगडाले हमारे यहाँ की शोध छात्रा है विभाग की। इनका शोध कार्य पूर्ण हो गया है, आज मौखिक की परीक्षा है। इन्होंने अपना शोध कार्य डॉक्टर राजीव कौशल जी के निर्देशन में किया है। और मैं विभाग की ओर से प्रोफेसर कश्यप जी का, जो कि बिलासपुर विश्वविद्यालय में प्रोफेसर एंड हेड रहे हैं, उनका अपने विभाग की ओर से, रानी दुर्गावती विश्वविद्यालय की ओर से और स्वयं की ओर से आपका इस प्लेटफॉर्म पे हम स्वागत करते हैं। और जो इसके अलावा जो भी अन्य प्राध्यापक जुड़े हुए हैं, मैडम कावेरी हैं, राजीव कौशल जी हैं और तमाम जो लोग जुड़े हुए हैं, उन सभी लोग का मैं स्वागत करता हूँ। और सर की आज्ञा से रानू से निवेदन करूंगा कि रानू आप अपना प्रेजेंटेशन जो है वो अपना पावर पॉइंट प्रेजेंटेशन दें और उस सर की सारे क्वेश्चन का जवाब दें। रानू।
थैंक यू सो मच सर। Respected Dr. D.D. Kashyap sir, Dr. Lokesh Srivastava sir, Dr. Rajiv Kaushal sir, Registrar ma'am, my colleagues and dear friends, a very good afternoon to everybody. Today I am presenting my research work entitled Spatial Distribution of Some Diseases in Balaghat and Sivnir District. So let me present my screen to you. एक सेकंड, ये कब यहाँ पे ये
कट कर दीजिए उसको। हाँ ठीक है।
Okay. So this research work comes under the very new branch of geography, that is medical geography, which examines the spatial aspects of health and diseases, examining how geographic variables, social determinants, and health outcomes interact. It strives to advance our knowledge of the prevalence of diseases, the cause of their occurrence, and the creation of successful methods for disease prevention, healthcare planning, and public health initiatives. As far as this study is concerned, I carried out this research in descriptive survey method, opted stratified sampling technique to draw samples from the population, and gathered necessary primary data with the help of schedule, Google Forms, self-administered interviews, and secondary data from various recorded and authentic sources. This thesis is organized in 8 chapters. First one is introduction, navigating the challenges. Second one is navigating the challenges of modern health, exploring contemporary issues and diseases. Third one is applied methodology to conduct the study. Fourth one, background information of the Balaghat and Sivnir district. Fifth, spatial distribution of diseases in Balaghat and Sivnir districts. Sixth chapter regarding result and discussion. Seventh chapter is regarding the healthcare facilities in India, a comparative analysis, and final 8th chapter is regarding summary, conclusion, and suggestion. For this study, I had objectives to analyze the incidence and distribution of selected diseases in the study area, for which I made hypothesis. Disease incidences will be uneven in the study area, which found to be true with the help of data analysis, chart, graphs, and maps. Second objective was to compare and analyze the spatial distribution of communicable and non-communicable diseases in the study area, for which I made hypothesis that non-communicable diseases communicable diseases will be more prevalent in comparison to non-communicable diseases, which also found to be true. Then my third objective was to compare and analyze the spatial distribution of nutritional deficiency diseases in the study area, which again found to be true. My fourth objective was to examine the degree of satisfaction of healthcare services in the study area, for which I made hypothesis that government healthcare facilities will be satisfactory in this study area, which again found to be true. Then my fifth and last objective was to examine the degree of health awareness in the study area, which again found to be true, for which I made hypothesis that degree of health awareness will be good enough in the study area, which found to be true. This is the chart where I draw my sample from the population with the help of stratified sampling. Then I collected primary data with the schedule, Google Form, self-administered semi-structured interview, participant observation. I also interviewed many government as well as private doctors, also quacks, which we know as Jhola Chhap doctors, and the patients admitted in the hospitals and also the local community. My first objective is very long, where I took up non-communicable, communicable, and nutritional deficiency diseases, which I showed with the data analysis that the uneven distribution of the diseases as malaria, as you can see, Balaghat, Baihar, Lanji, Varasuni, Kirnapur, Khairlanji, Lalbara, Birsa, Paraswara, Katangi, Siuni, Lakhnadon, Ghansor, Chapara, Kurai, Dhanora, Balaghat, and Kevlari district, all that has uneven distribution of the non-communicable diseases like malaria. Then second one was, I also depicted it with the help of map, and with the in the result, I would not elaborately explain it, but I would like to tell you that malaria is generally known as a disease of poverty because it is so common in area where there is significant poverty. Madhya Pradesh is one of the central Indian states with the highest rates of malaria morbidity and fatality. Among all the blocks of Balaghat and Sivni district, the relative incidence rate of malaria was highest in the Balaghat block with the RI value of 1.52 and lowest in the Khairlanji block with the RI value of 0.60. As per the research hypothesis number 1, uneven spatial distribution of malaria in different blocks of Balaghat and Sivni district, shown in the figure 6.1, descriptive statistical measures of malaria are shown in above table 6.2 with the statistical measurement and graphical representation. Hypothesis 1 is proved true. And overall, I hate all the diseases which are malaria, diarrhea, typhoid, AIDS, cancer, diabetes, cardiovascular, kidney diseases, then nutritional deficiency diseases, anemia, beriberi, scurvy, and ricket. All were found uneven. All are found uneven distribution and incidences in the study area. My second objective was to compare and analyze the spatial distribution of communicable and non-communicable diseases in the study area, which again found to be true. This is the chart of the relative incidences of all the communicable diseases, malaria, diarrhea, typhoid, AIDS, and non-communicable diseases, cancer, diabetes, CVD, and kidney diseases. As you can see, the graph also shows that communicable diseases are more prevalent in comparison to non-communicable diseases. This is the result and discussion of the second hypothesis and objective. In the present study, relative incidence rate of communicable diseases were higher in comparison to non-communicable diseases. As shown in the figure 6.13, diarrhea had highest incidence rate followed by typhoid, malaria, and AIDS among the communicable diseases. Similarly, diabetes had highest incidence rate followed by cardiovascular diseases, kidney diseases, and cancer. It is very much clear from the above comparative graph that incidences of communicable diseases are higher in comparison to non-communicable diseases. Hence, hypothesis number 2 proved true that communicable disease will be more prevalent in comparison to non-communicable diseases. Here are some reasons responsible for the communicable diseases, also known as infectious or transmissible diseases, if spread more easily compared to non-communicable diseases due to several factors that are mode of transmission. Communicable diseases are typically caused by pathogens such as bacteria, viruses, fungi, or parasites that can be transmitted from person to person or through contaminated objects, food, water, or vectors, mosquitoes, ticks. These modes of transmission facilitate the spread of the disease from an infected individual to susceptible person. Also, human behavior and social factors are responsible. Communicable diseases can be influenced by human behavior and social factors. Factors such as crowded living conditions, poor sanitation and hygiene practice, inadequate access to clean water, and lack of knowledge about disease prevention can contribute to the spread of communicable diseases. Additionally, factors like international travel and migration can facilitate the global spread of infectious diseases. Rapid evolution and adaptation of pathogens, then lack of community public health challenges. Environmental factors are also responsible for the spread of communicable diseases. Then, my third objective was to compare and analyze the spatial distribution of nutritional deficiency diseases in the study area, for which I made hypothesis that incidence of nutritional deficiency diseases will be uneven in the Balaghat and Sivni district. Through the graph and data analysis, I showed it. This hypothesis also proved true. Then, relative incidence of the nutritional deficiency district in the Sivni district also proved uneven. That, as you can see with the graph and data analysis, that nutritional deficiency diseases are also not evenly distributed. This is a comparative graph of nutritional deficiency disease in Balaghat and Sivni district. This is the result of the third hypothesis. As per the objective number 3, to compare and analyze the spatial distribution of nutritional deficiency diseases in the study area, the relative incidence rates of all nutritional deficiency diseases were compared with reference to Balaghat and Sivni district, and found that the nutritional deficiency disease incidences were higher in Balaghat in comparison to Sivni district. With the statistical measure and graphical presentation, hypothesis number 3 proved true that NDD, nutritional deficiency diseases, will be unevenly distributed in Balaghat and Sivni district. Present study reported that the tribal blocks of Balaghat district were found more anemia cases as compared to the other blocks. My fourth objective was to examine the degree of satisfaction of healthcare services in the study area, for which I had research hypothesis on the general observation that government healthcare facilities will be satisfactory in the study area. So I sent Google Forms to my sample size and asked the question like, how satisfied are you with the availability of government healthcare facilities in your area? So 33.8% were
Ranu?
satisfied. Yes, sir.
रानू,
Yes, sir.
ये प्रेम ने कौन है? ये प्रेम ला रहे हैं, इन्होंने अपना प्रेजेंटेशन चालू कर दिया तुम्हारा बंद करके.
Oh no,
ये कौन है प्रेम?
I don't know, sir.
तुम्हारा प्रेजेंटेशन नहीं आ रहा है, इसको बंद करने को बोलो. प्रेम अपना बंद करिए. प्रेम कौन है?
उनका बंद कर दिया है मैम. आप फिर से एक बार स्टॉप करके प्रेजेंट कर लीजिए प्लीज.
Okay, okay. स्टॉप शेयरिंग. अच्छा, फिर से करिए.
पता नहीं कौन प्रेम है, ये चालू कर दिया है.
अरे कोई इशू नहीं.
अभी नहीं शुरू हुआ आपका प्रेजेंटेशन.
यस सर, हो जाएगा.
हाँ ठीक है.
यस सर. इज इट विजिबल?
हाँ, प्रेजेंटेशन मोड में ले लो.
Yes, sir. My fourth objective was to examine the degree of satisfaction of healthcare services in the study area, for which I had research hypothesis on general observation that government healthcare facilities will be satisfactory in the study area. So I had questioned, how satisfied are you with the availability of government healthcare facilities in your area? So 33.8% were satisfied. A few percent were very satisfied, 37.7% were neutral, then a very low percentage were not satisfied. Then I had questioned, how satisfied are you with the quality of medical services provided by government healthcare facilities? So 32% were satisfied, 8.1 were very satisfied, and 37.2 were neutral about the idea. Then I had questioned, on a scale of 1 to 5, how would you rate the cleanliness and hygiene of government healthcare facilities? 42.3% were agreed that government healthcare facilities are good enough and maintain very much hygiene. Then I also asked about the which government facilities are benefiting you. So 216 samples, about 36.4% said that Ayushman Bharat Pradhan Mantri Yojana benefited them. Then 11.4% used Pradhan Mantri Suraksha Bima Yojana. Then Pradhan Mantri Jan Aushadhi Yojana benefited 11.6% of the samples. Then Rashtriya Swasthya Bima Yojana also benefited also catered to the samples, and National Health Insurance Scheme was also able to satisfy 10.6% of the people. 0.2% said that आवश्यकता नहीं पड़ी, they were not needed any government facility, as maybe they were not ill, or okay. Then this is the residents percentage benefited of various government medical schemes. Result and discussion. In the present study, 440 residents were asked 5 questions using Google form regarding the level of satisfaction towards healthcare services among the residents of the study area. Questions were asked regarding the satisfaction level for the availability, accessibility, quality of government healthcare facilities. Questions were asked about professionalism and competence of healthcare staff in government healthcare sector, and a survey for residents were conducted regarding the financial healthcare schemes, in which I found that residents are very much aware about the schemes and they get benefited from these schemes at times. Also, it was seen that a section of population were neutral about their opinion. Hence, it is proved that with the reliability testing of the questionnaire with Cronbach alpha test that was excellent, and residents of the study area were satisfied with the government healthcare services. Hypothesis number 4 proved true. Then my fifth and last objective was to examine the degree of health awareness in the study area, that for which I made hypothesis on the general observation that residents of the study area will be aware of their physical and mental well-being, for which my first question was, on a scale of 1 to 5, please rate your overall physical health. Then 44% found their 44% of the sample size said that they are very much aware about their health. This pie chart shows the exact data of how much people were satisfied, and how much average, and how much was 11.3 was excellent. Second question was, how would you rate your mental well-being? 19.2% said that they are satisfied with their mental health and they found it sound. Then 13.1 said blissful, that they have good mental well-being. Then 13.5 stressed out and extremely stressed were around few percent said that they are extremely stressed. My third question was, how well do you maintain a balanced and nutritional diet? 59.4% said that they have good food and they are getting nutrients, but I do contradict this result, because as they are saying that they are having good food, but Indian plates are not good enough enriched in terms of nutrients. Our plate is not full of nutrients. On a scale of 1 to 5, how often do you experience stress-related symptoms, headache, muscle tension? So 16.8 said rarely, 22.2 said never, and 9.9% said often, and sometimes were 45.8%. A pie chart. This is the pie chart showing degree of stress-related symptoms, headache, muscle tensions, or of the residents of the study area. In the present study, again, the primary goal of this research project was to examine the prevalence of distribution of a few selected communicable disease, non-communicable diseases, and disease associated with nutritional deficiency. It tries to identify the primary environmental factors that contribute to the spread of various environmental diseases, as well as the primary nutrient deficiencies in people diets that may contribute to a variety of nutritional elements. As a result, the case of study is formed by the environmental, dietary, and disease-related causes causal agents. This examination is done from the perspective of the biophysical environment, human economic characteristics, and social cultural tendencies. This is the spider web diagram of communicable diseases in the study area. Then non-communicable diseases, nutritional inadequacy, or summary conclusion on disease prevalence in Madhya Pradesh, that malaria, two main types, Plasmodium falciparum and Plasmodium vivax, are found in the Madhya Pradesh. Seriousness of Plasmodium falciparum emphasized. Health department strategies: fever surveys, diagnostic examinations, larval examination, fumigation, and public awareness campaigns. Then LNI and mosquito nets distributed with local awareness program. Reason of typhoid: rainy season seen as a surge in typhoid cases due to contaminated water and outside eating. Contaminated drinking water and unclean food sources contributed to the spread. Emphasis on proper cleanliness management to prevent typhoid. Then tuberculosis, national campaign to make India TB free by 2025. Challenges include patients seeking TB medicine from private practitioners, causing financial loss and worsening cases. District targets set for detective new TB patients under the campaign. Anemia, superstitions and lack of awareness hinder efforts to reduce maternal mortality. I would like to mention the data that most of us are anemic. We don't know that we are anemic. Our hair fall, our uh, fatigue, and so many daily life problems comes under this anemia, and we really don't go to the doctors to make us check up and to make sure that we don't be anemic and have proper food, proper iron in our diet. Then cancer, increasing cancer cases attributed to a lack of awareness and rising addiction, especially to gutka and bidi. Oral, breast, and uterine cancer prevalent. Timely treatment and awareness crucial for a 100% survival rate. Excessive production of tendu leaf and bidi tobacco contributes to oral cancer. In conclusion, addressing disease prevalence in Madhya Pradesh requires a multifaceted approach, including awareness campaigns and preventive measures and targeted healthcare interventions. The insights from healthcare professional and official provide valuable perspective for formulating effective strategies to combat these health challenges. I also interviewed many private and government doctors. So one of the resident doctor in viewpoints of the a resident doctor, in a deep conversation with a doctor in Balaghat, I came to the conclusion that problems he faces as being doctor in Balaghat, that lack of infrastructure, lack of facilities, lack of interest by government in healthcare sectors, lack of awareness among general population. Most of the population here belong to the rural areas, and where there is no nearby established hospital in their vicinity, so people ignore their disease and they do not seek medical attention until the disease is really distressing and worsen. Quacks, this is the term used for local practitioner. As I told you that in very bad term we call them jhola chap doctors, who treat without any formal medical education. They are not able to even diagnose the disease properly, still they treat the patient. Most of them give symptomatic treatment and not the root disease. They don't go to the root, but as seeing the symptoms, they give general medicine. Sometimes patient get really worse in condition. When after trying enough, patient doesn't get better, then the patient is sent to doctor, and by that time the disease would have been progressed. Then problem of bribery, commissions, which I was shocked to get the point that commission in healthcare system. This is my personal observation, that the quacks, ASA workers, and ambulance drivers will bring the patient to the hospital not for the treatment but for their commission. They get commissioned by the private doctors, and they bring patients to their private hospitals, and they are getting richer we can say, and they are earning money by them. And asa karyakarta, asa workers, ambulance drivers, they are taking benefit from the sufferings of the patients. The more you pay them, more number of patients you get from them. In the private system, the biggest mistake is of the hospitals that have spoiled the system by paying them large amount. The cost is ultimately beared by the patient, because patient have to pay them, and patient have to pay the private doctors because fees are very high. Lack of trained staff in the hospitals, uh, in the hospitals, and also lack of interest of learning. People do not want to spend money on their health, and that's why they don't go to regular checkup. Even though if they get sick, they avoid their health. Money making and overcharging by the hospitals, that is also the reason that people don't go to the hospitals, because they private hospitals are overcharging. People are wrongly consulted by the quacks or jhola chaps about the doctors and the diseases. Biggest challenge of a doctor to win patient trust. One of the Dr. Nicholas Vasnik told me that uh, it is the assumption of the patient in the Balaghat district that Balaghat का जो बेस्ट डॉक्टर है वो भी नागपुर के वर्स्ट डॉक्टर से बहुत अच्छा है, ऐसा ये मानकर चलते हैं, और नागपुर प्रेफर करते हैं जाने के लिए, ना कि जो वहाँ के गवर्नमेंट हॉस्पिटल से वहाँ पे. Then there are so many viewpoints in by the patients also, that nutrition. This is the map which shows that this area need to be covered by the health facilities, as it is empty, and people have to rush to the distance. Then for my thesis, at last, I would like to make some suggestions that provision of uncontaminated drinking water to the people in rural area. People are taking water of the well, which is not very pure, and induction of nutritional and health education oriented programs must be run. Village health guide provision in the study area as a remedy to minimize the harmful effects of uh, if, uh, as a remedy to minimize the harmful effects of disease is not, if not removed completely, following suggestions are made. The implementation of these will definitely help in the practice or full removal of the prevailing hazards of the people of the study area, and to improve the health of the people in comparison to the present. First of all, the people should be aware of the disease caused by nutritional environment, for which literacy and awareness should be generated. Utmost importance in the is the supply of pure and safe drinking water, especially to the rural population, to keep them safe from the disease caused by polluted or contaminated water. The sanitation, drainage, and ventilation availability of fresh air systems should be improved, especially in urban areas. The employment opportunities in urban and rural areas must be enhanced to increase the purchasing power of the general public. This will ultimately result in the upgrading of standard of living of the overpopulation of the study area. Educational facilities should be more particularly job-oriented education to enable the youth to get fruitful employment. Medical services should be considered much more to the number of primary health sub-centers should at least be doubled than that of the present number, to reduce the distance to be traveled to reach a hospital, which is up to 50 kilometers in the remote areas of the region. In addition, local people should be trained as compounders health guide to provide instant medical care in the rural areas in each village, as they have to go to quacks. In place of quacks, they can go to compounders also, which are very trained. The water resources should be kept free from pollution by addition of waste of industries. The air pollution in coal and manganese mines areas should be minimized to avoid disease in the surrounding areas. Afforestation of the denuded forest to maintain the environment. Looking to the poverty and backward of the study area. Call for change in India's public health discourse. Infrastructure norms it should be increased that government norms for healthcare infrastructure are not met. Urgent action is needed to ensure CHC community health centers per 80,000, one primary health center per 20,000 and one sub health center per 5,000 population in tribal area. Human resource development strengthen Ayush services, attract medical professionals to remote areas, and create appropriate proportionate post for doctors based on population growth. Administration and policy enforce stringent regulations for antibiotic prescriptions, adopt a comprehensive healthcare systems, allocate 30% of foreign donations for health system, standing and regulate unethical medical practices, staffing and training, telemedicine and e-health services, outreach program, organize health camps and outreach programs in rural areas for essential healthcare services and health education. Mobile clinics must be established, introduce mobile clinics with basic facilities to provide primary healthcare services in remote regions. Community engagement, encourage community participation in healthcare initiatives through awareness campaign and involvement of local organizations. Medicines and supplies must be very efficient. Health insurance, promote health insurance scheme for financial support, as government are taking very much initiatives to make the people health insured. Collaboration and partnership, foster collaboration between government bodies, non-profits, private providers, and corporations to leverage resources. Then monitoring and evaluation of the health practices must be must be very efficient so that things should go in a smooth manner. Private clinic registration, expedite the registration process for private clinics and centers to address delays caused by government disinterest. Recognition of quacks, acknowledgement of role of quacks in emergency situation, run training program to make them skilled and provide diplomas for better services. That was in news also that quacks must be provided with training so that they can cater the health facilities. While my conversation to the local community, so many people told me that quacks are the emergency health providers to them, because जब कोई भी available नहीं होता है और रात में या मतलब at night they need emergency, quacks are the gods for them. So thank you so much. Scope for the further research, the nutritional deficiency diseases should be studied separate to know their specific causes, mode of occurrence, and remedy. Environmental aspects should be studied in smaller units for better and critical studies leading to microenvironment. Then important disease must be individually taken up for study. Waterborne diseases, dysentery, diarrhea, or so many important, which is waterborne. These are prevailing almost amongst the children, causing a high morbidity, may be studied separately, and a specific study on chances of AIDS tribal dominated areas is suggested as a safeguard for future generation. Thank you so much.
Professor Kashyap sir. Professor Kashyap sir. कश्यप सर हैं कि नहीं, चले गए?
Face some network issue.
ऐसा तो नहीं तुम सब बोल डाले हो, उन्होंने सुना ना हो कुछ? एक मिनट चेक कर लूँ जरा.
He was there just a minute before I checked in.
इनसे बात भी तो हुई है हमारी ना, उसके बाद पता नहीं क्या होगा. He is no more, यहाँ है ही नहीं. राजीव जी टेलीफोन लगाइए उनको. राजीव जी बात करिए टेलीफोन लगा के. राजीव जी सुन पा रहे हैं मुझे? हेलो, मेरी आवाज आ रही?
Yes, sir. Yes, sir. He's calling.
राजू सर,
Yes, sir. He's calling him up. सर ही इज ज्वाइनिंग, वो कनेक्शन लॉस्ट हो गया था उनका. ही इज ज्वाइनिंग.
हेलो.
हाँ सर. सर
हेलो सर.
जी सर, बोले सर.
ये
कश्यप सर, आपको सुन पा रहे हैं हम लोग.
हाँ हाँ, मैडम रानू.
यस सर.
मैडम रानू,
यस सर. यस सर. यू आर ऑडिबल. आई कैन हियर यू.
आपने सेकेंडरी डाटा जो है,
यस सर.
सेकेंडरी डाटा जो है वो डिस्ट्रिक्ट हॉस्पिटल से लिया था.
Sir, yes, sir. I went to the district hospital as well as block, but data was not coherent as I told you. Ki people are also going to the nearby famous city like Nagpur. So data were actually not coherent. From everywhere I collected the data, data was diverse. Sir, am I audible to you? Network issue. Maybe he is facing some network issue. माइक म्यूट है. सर आपका माइक म्यूट है. कश्यप सर. या.
हेलो.
यस सर.
अच्छा, ये बताइए आप
यस सर.
कि आपने जो फील्ड सर्वे किया है,
या जी.
तो क्या लोग इजली आपको ये विभिन्न जो डिजीज आपने बताया है,
यस सर.
एड्स के बारे से वो क्या समझते थे?
सर बहुत सारे लोग एक्चुअली ये इशू है कि पहले तो वो रिकॉग्नाइज ही नहीं कर पा रहे हैं. देन जब कुछ सिम्टम्स उनको समझ में आ रहे हैं, वो डॉक्टर के पास जा रहे हैं. तो मैंने बताया कि क्वैक्स इनिशियल तो वो जो झोला छाप डॉक्टर्स हैं या समथिंग, या अभी प्राइमरी हेल्थ सेंटर्स, तो वो जाते हैं लेकिन उतना रिकॉग्निशन, मतलब उनको आइडेंटिफाई रूट कॉज नहीं पता चल पाता. तो वो लास्ट स्टेज पे जा रहे हैं, तो उसकी वजह से वो डेथ कॉज जो है वो बहुत ज़्यादा बढ़ रहा है. और बहुत सारे पेशेंट्स जो हैं वो आफ्टर रिकॉग्निशन ड्यू टू सोशल असेम्प्ट, क्योंकि उनको शर्मिंदगी होती है, अभी तक उनको अवेयरनेस नहीं है उतनी, तो वो जाते नहीं हैं. रिसेंट डेटा 814 लास्ट ईयर का डेटा था कि 800 समथिंग 850 समथिंग वर रिकॉग्नाइज्ड इन द एंटायर बालाघाट डिस्ट्रिक्ट, और सिर्फ 614 लोग जो हैं वो ट्रीटमेंट करवा रहे थे.
नहीं, तो आपका प्राइमरी डाटा और जो सेकेंडरी डाटा है वो कोरिलेट करता है कुछ?
सर प्राइमरी डेटा इससे सर कोरिलेट तो कर रहा है, लेकिन डेटा वेरी कर रहा है इन द सेंस कि एक डायरेक्शन में जा रहा है, लेकिन डेटा सपोज मैंने 10 कलेक्ट किए हैं, मतलब 10 मुझे एड्स के केस मिले हैं, तो वो वहाँ पे जो है उतना मतलब वेबसाइट पे जो उन लोगों ने चेकअप किए हैं या उनका जो रजिस्टर है उसमें वो बहुत कम है.
अच्छा, कास्ट वाइज कुछ कोरिलेशन आपने किया है? कोरिलेट?
सर नो सर, कास्ट वाइज नहीं किया, बट हाँ एक ट्राइबल कम्युनिटी वाला जो मलेरिया एंड और जो रूरल एरिया वाला था उसमें मैंने किया है। तो रूरल एरियाज में क्योंकि वो मॉस्किटो नेट्स और ये सब यूज नहीं करते हैं तो इसमें थोड़ा इशू है।
अच्छा, गवर्नमेंट की जो विभिन्न योजनाएं हैं
यस
उनका क्या इम्पैक्ट है इस पर?
सर ये मतलब मेरे लिए भी बहुत शॉकिंग था कि जो रूरल कम्युनिटी है वो बहुत ज़्यादा अवेयर है, क्योंकि सब हेल्थ सेंटर्स जो हैं वो उनको प्रोवाइडेड हैं। आशा कार्यकर्ता जब वाइल प्रेगनेंसी ऑल द वीमेंस ऑफ द मतलब एंटायर विलेज आर गोइंग टू टेक न्यूट्रिशन फूड, वो जो दलिया का पैकेट्स मिलता है, और आयुष्मान भारत मतलब योजना और बहुत सारी जो योजना है उनके बारे में वो ज़्यादा जानकार हैं। मतलब ये मैंने अपने जो व्हेन आई वाज कलेक्टिंग द डेटा, तो अर्बन पीपल से लाइक नॉर्मल जो पीपल हैं जिनको इतनी जरूरत नहीं है, बीपीएल वाले स्पेशली, उनको बहुत अच्छे से पता है कि कौन सी योजना है, कौन हमको बहुत अच्छे से कैटर कर सकते हैं।
नहीं तो आपके रूरल एरिया में
यस सर।
एलोपैथिक और होम्योपैथिक और आपका ये आयुर्वेदिक का क्या इम्पैक्ट है?
सर फ्यू वी कैन से, क्योंकि क्या होता है कि जब वो हो जाता, जब डिसीजेस हो जाती हैं, व्हेन डिसीजेस अकर दे नीड इमीडिएट क्योर, क्योंकि दे कैन नॉट अफोर्ड टू बी इल फॉर लॉन्ग टाइम, तो वो फिर जो हमारा एलोपैथी है उस पर ही ज़्यादा प्रेफर करते हैं। अ वेरी फ्यू नंबर ऑफ पीपल विलिंग टू ट्राई होम्योपैथी, क्योंकि बहुत टाइम लगता है उसको ठीक होने के लिए।
आजकल योगा की बात करते हैं लोग।
यस सर, यस।
तो इस रेफरेंस में क्या व्यू है लोगों का वहाँ?
सर योगा तो नहीं करते हैं लोग, जो मैंने जितना देखा है और जितना मैंने डेटा गैदर किया, तो क्वेश्चन पूछा था, बट वो रेगुलर प्रैक्टिस में नहीं है उनके।
चलो, ओके श्रीवास्तव जी।
जी सर। सर
आप पूछ लीजिए।
नहीं बस सर, मैंने तो छात्र का काम देखा है, वो यहाँ से डिपार्टमेंट की छात्र है, तो वो तो लगातार हमसे संपर्क में रही है और काम होता आया है सर। आपने बहुत सारे क्वेश्चंस पूछ लिए, और आगे जैसा आपका आदेश, तो आगे कार्रवाई कीजिए।
ओके सर, अपने तरफ से तो ठीक है सर।
तो आप इनको आशीर्वाद दे दीजिए और बधाई दे दीजिए। तो
गुड विशेस है और कांग्रेचुलेसन।
थैंक यू सो मच सर।
अच्छा रानू जी, सर की ओर से बहुत बहुत बधाई दी गई और मेरी ओर से भी, और विभाग की ओर से आपको बधाई दी जाती है। डॉक्टर बनने के लिए एक आपका जो दूसरी कदम था ये समाप्त हो गया, अब नोटिफिकेशन का इंतजार रहेगा।
यस सर, थैंक यू सो मच। थैंक यू सर।
राजू जी आप धन्यवाद ज्ञापित करते हैं।
मिस्टर राजीव जी को भी कांग्रेचुलेसन।
जी सर,
बहुत बहुत धन्यवाद सर, बहुत बहुत धन्यवाद। आज के इस ऑनलाइन पीएचडी वाइवा में जुड़े हुए मेरे सहपाठी प्राध्यापक डॉक्टर लोकेश श्रीवास्तव जी, डॉक्टर डी कश्यप जी, डॉक्टर बीएन त्रिपाठी जी, प्रोफेसर एसी तिवारी जी, तृप्ति सोनी मैडम, आप सभी लोगों का, और भी जो प्राध्यापक और छात्र छात्राएं इस ऑनलाइन पीएचडी के वाइवा में शामिल हुए, उन सभी को मेरी तरफ से बहुत बहुत धन्यवाद, और मैं सब उनका बहुत 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 आभारी हूँ। और रानू रंगडाले को बहुत बधाई, बहुत बहुत बधाई, धन्यवाद, धन्यवाद, थैंक यू।
राइट सर।
श्रीवास्तव जी आइए बिलासपुर कभी।
है सर।
श्रीवास्तव जी आइए बिलासपुर कभी।
जी सर, आएंगे, जरूर आएंगे सर, बिल्कुल सोच रहा हूँ कि उधर कोई मौका मिल जाए या कुछ ऐसा कार्य निकल आए तो आपके आना होगा सर।
जी 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 सर,
बिल्कुल ठीक है सर। राइट,
ठीक है सर, ओके सर,
थैंक यू, नमस्कार सभी लोग को, नमस्कार भैया।
ओके सर।
Thank you so much, sir. And I'm coming to the department. Thank you everyone who joined. Archana ma'am, Sasi sir.
Congratulations.
Thank you ma'am. Thank you so much. Thank you for joining.
मैडम बहुत बहुत बधाई आपको।
Thank you so much, Sasi sir. Thank you everyone. And we should sum up that I told you that it will be finished soon, but it took a time.
Congratulations, Ranu ma'am.
Thank you, Jyoti. Thank you, everyone. So, shall we? Yeah, thank you so much. Shall we sum up now? Okay. Thank you so much, everyone. Okay, I'm stopping.